welcome back to the channel, or welcome to the channel if you're new here. Today, I had the honor of hosting Dr. Jennie Byrne. She's a psychiatrist, a psychotherapist, an author. She's got 2 books at the moment. The most recent is the one that we'll be talking about today, and that is Moral Injury: Healing the Healers. This topic is extraordinarily important because you hear so much about burnout. And as Jennie will talk about from her expertise and all the interviews that she had for her book, we are missing the mark. And unfortunately, when we are grouping what is potentially moral injury into burnout, then people aren't given the appropriate tools in order to truly heal. So, as you settle in, I recommend that you grab something to write with and something to write on as we dive in to moral injury. And I do want to appreciate Jennie for sitting with me as I sat during a power outage with no lights. And if you're observing that things are a little bit off, I appreciate your patience too. And I trust that me sitting without lights did not take away from this deeply meaningful and important discussion from Dr. Jennie Byrne on moral injury. So thanks for being here. Make sure to share your thoughts, your comments, your reflections as you tune in down below. Let's hear about what really drew you into this topic that we're going to be discovering today, moral injury and the world of psychiatry.
Yeah, I'm excited to chat with you. So about me, I think for your audience, probably some of the interesting things they might be curious to know about me is I did not know I wanted to be a doctor. When I grew up, I was not one of those kids. I liked science, but I was really into music and art and actually started out as a music performance major in college. So I had a very meandering path to medical school. And path has continued to be meandering, but I'm was the kind of doctor who wanted to fix things, not just individuals, but when something wasn't working in the system around me, I fix that.
Mm.
And so I found myself getting pulled into a lot more business, a lot more operations, thinking bigger picture about how to fix the system. So did that at the state level, did that at a private practice level, did that at a national level, and now focus a lot of my work on advisory with earlier stage companies. Because as you know, many listeners probably know, it's a lot easier to build something from the ground up as opposed to go back and try to fix a system that's been around for a long time. So
Yep.
I love it. And I work with a number of small companies. I also incessantly curious. I always like to learn. It's probably why I have an MD PhD because I geek
Mm-hmm.
out a lot. And
Yep.
that led me to write my first book in 2023. And then I published the book we're going to talk about today a couple months ago.
And for the people who I hadn't mentioned your first book, can you tell them what the title of that and what's it about?
The first book is called Work Smart, Use Your Brain and Behavior to Master the Future of Work. And it was really born out of, pandemic. We all had to make it work. I felt like there were no answers and I wanted answers. So I started researching as a neuroscientist and a person who loves all things brain and behavior. And then somebody urged me to, and I did a bunch of interviews and found out that I actually really liked writing. I love reading, but I didn't know that I also enjoyed writing.
That's great. Well, fortunately for us, you enjoy writing. You wrote about a topic which was near and dear to my heart because
Yeah.
when I heard people talk about burnout, I'm like, we're missing something. And actually, we got connected because I said, this is so much more moral injury. People were resting and not recovering or going right back into what I call the trenches as a former military person. And you captured it so well because I had made a post. I said, I think a lot more of this is moral injury. And they're like, heck, Dr. Byrne just wrote a book about it. Matter of fact, we got in touch and I said, I need this conversation to happen to hear your expertise. I read your book. I loved it. I highly recommend people dive into that. I will share that link down below to the book. But can you share what, you wrote the book, I think in 4 months. You just had this
Yeah.
urge, I have to get this out there. Can you explain more about that urge and the need to get this information into the reader's hands?
Sure. So, as I mentioned before, I spend a lot of my time doing advisory work. I still do some clinical work with individuals, but over the past, I guess, maybe year or so, I've been really seeing other clinicians and other healthcare leaders struggle. And I have this kind of unique seat where I'm a shrink. So, for some reason, people just like to tell me things. And I sit in the room with the C suite, I sit in the room with the boards, I sit in the room with the clinicians. So I get this kind of interesting perspective from all angles. And what I was feeling, and that's the urgency to write, was that this problem that clinicians are suffering is much, much worse and deeper than people know. And it's having a ripple effect in all of the healthcare ecosystem. I've experienced as a patient, as a caregiver to my parent and my child. I've experienced it as someone who's trying to manage other clinicians to let
Mhm.
them do their work. I've seen it at the highest levels. And I felt like there was also this kind of narrative that frontline clinicians were the heroes and corporate leaders and executives were the villains. It didn't resonate right with me because I sit in those rooms, I hear them suffering, and they whisper to
Mhm.
me as soon as we're behind closed doors, like, I'm miserable, I feel terrible, I don't know what to do. My clinicians feel terrible, I don't know how to help them. I'm in the middle. And then I hear from the CEOs who aren't clinicians, like, I got into this business because I felt like there was more of a mission than other corporate work I could be doing, but I don't know what to do. What's going on with these clinicians? I don't understand. I'm hearing all these things. They're leaving. I can't staff my buildings. I can't like run this business. And I don't, most of them are not villains at all. They could make a lot more money, honestly, doing something else, the same as you and I or other clinicians could make. We're smart. Like, if all we cared about was money, we could find other ways to make a lot of money. So, long story short, there's this profound suffering and it's having a very real impact on everybody. And I don't see it getting better. And the discussion around burnout to me did not improve the situation at all, maybe
Mhm.
even
Yeah.
made it worse
Yeah.
because it
Mhm.
was mislabeling. So
Mhm.
I just kind of, like the first book, I got curious. I was like, well, I'll just start researching, I'll talk to people. And I came across a colleague here in North Carolina named Dr. Warren Kinghorn,
Mhm.
who, like you, has this interesting perspective as a military clinician. So he works at the VA primarily. He's also a psychiatrist and he's also a chaplain and has a divinity degree. So
Wow.
we had this really deep conversation kind of on the philosophy of moral injury, which comes from military experience.
Yep.
And after that conversation, I was like, oh, okay, now this makes sense to me. So then I decided, that's when I was like, I'll get a book done in 4 months, which was very ambitious. Um, but I really felt like, okay, now I have a path to start interviewing people, talking about what's going on. I have a framework that I can understand and that I think other people can understand.
I appreciate that. I actually was able to label it. I was the VA getting care out after I left surgery, and I didn't know what happened. I actually didn't know there was ubiquitous suffering. I thought it was just me at the time, which I know happens a lot. Now it's more in mainstream conversation, but that was 2014, 17. And I went to the VA after I was discharged from the military, and the sign was about moral injury, and it described the reasons, the causes, and the symptoms. And I was like, that is what we're dealing with. And this is again before I heard people talking about burnout. And then also I had resistance within my own self because I'm like, oh, this isn't moral injury. And because I associate like untreated moral injury is going to put people at high risk for PTSD. And I had developed this mindset that we don't have PTSD. We're not going to war. And now I see all the signs and symptoms of moral injury and PTSD in our healthcare professionals. And I do find that the treatment, as you know very well, I'm just saying this for the audience, the treatment for moral injury, burnout, and PTSD is different. So, can you explain more about these differences?
Yeah, and I like the fact that you brought up PTSD, which also comes from the military experience, because that was what they were trying to figure out. They're like, this doesn't look like PTSD alone.
Yeah.
Yes, there's some PTSD, but these are typically soldiers coming back who were never in combat. Their lives were never in danger. it didn't really match the definition of PTSD. So the difference between the three, and they certainly are like a Venn diagram where there's overlap, and that's why I think it's a little confusing. So in my words, burnout is more of a physiological state, mental and physical state of being, where you are simply exhausted. You're mentally depleted, your body is depleted, probably your immune system isn't working very well. Probably you're not eating very well, you're not sleeping very well. You're just literally exhausted. And to me, that's more of an industrial kind of framework. Like burnout is like a light bulb, right? A light bulb
Yeah.
burns out. What do? Go recharge it,
Yeah.
pop it back in,
Yep.
or go get a new light bulb.
Yep.
And that was the advice a lot of people were getting, right? Like go take a vacation, do yoga, meditate. And yeah, sure, that helps.
Mm-hmm.
There's nothing wrong with that, but that clearly wasn't fixing what was happening. So then the next thing is kind of PTSD. And PTSD is this mind and body reaction to a significant trauma. And again, most people have some kind of trauma happen in their life at some point, but how the state of being that your mind and body is in when you receive that trauma and the treatment you get for that trauma and your genetics and other, how you grew up, all those things determine what happens. And not everybody who has a trauma gets PTSD.
Mm-hmm.
I think that's a myth. Most
Yeah.
people feel like, well, everybody who was exposed to this thing will become, have PTSD, and that's not true.
Yeah.
So if you're burned out and where I think one of the things happening in healthcare was clinicians were burned out, they were exhausted, and then COVID and the pandemic hit, and that was like the final straw. Like the trauma of that was the final straw. So those are those two. Treatment for PTSD, there's a couple different treatments. There are some ways that you can actually kind of rewire your brain using some really interesting techniques. There's medicines, there's psychotherapy. So those are kind of the treatments for PTSD. Then you get to burnout, you get to moral injury. And moral injury, the core definition I'm using comes from the military. That is three things. You do something, witness something, a part of something that goes against your values, whether they're personal, family, religious, professional values. It is number two, either ordered or sanctified by somebody superior to you. And then number three, you feel the stakes are high.
Mm.
So you can imagine a clinician going about you were a surgeon.
Yeah. Mm-hmm.
I think surgery is maybe a good example. It's easy to imagine the stakes being high in
Yeah.
surgery,
Yep.
whereas
Mm-hmm.
maybe for other types of clinical work, it's not quite so concrete. But you feel the stakes are high, right?
Yeah.
Most clinicians I know feel the stakes are high when you're expected to be basically 100% perfect 100% of the time, which we are.
Mm-hmm.
Especially physicians, we're expected to be that. So the treatment or the way to heal, I like the way it's described as healing moral injury. I think it is a wound.
Yeah.
It's kind of a wound on your soul.
Mm-hmm.
And you don't fix a wound, as you know, you're a surgeon.
Yeah.
You provide the right environment for the body
Mm-hmm.
to heal itself. And that's what's so interesting about surgery. Actually,
Mm-hmm.
the body is doing most of the healing on its own, right? You're just providing, you're minimizing damage, you're suturing, you're taping, you're telling them to rest, you're giving them supportive liquids, you're creating an environment where the body can heal itself. And I love the idea of moral injury as being a wound that can be staged, and that the treatments to heal wounds are different for the different stages. That's how I'm thinking about the difference between the three.
Yeah. And when I was very judgmental about myself, is like, I've done all this resting and I'm not feeling any better. And it was because it wasn't facing that exactly what you're saying is, well, one, a lot of us rest and go right back into the scene of the crime type of thing, the system. And if people aren't familiar with moral injury and like even just the healthcare system, a lot of people say, well, I want to be a person that heals, but then they're working in a system that creates barriers to what they imagine it requires to actually be a healer, even holding space and sitting with a patient. if we're in and out and at high risk, we're making mistakes, we're sleep deprived, we're not set up for success, we're low resourced. So we're constantly feeling like we're set up to fail. And if you feel this sense of moral obligation to stay in medicine, quote unquote, especially clinical medicine, not realizing that's not the moral type of healer that you might have crafted in your own mind, right? I don't anticipate a lot of people, if they could have imagined what type of healer and practitioner of medicine that they envisioned for themselves, I don't think that they would have constructed the current system that we have. So like I always want people to give themselves permission. So many are resisting changing their clinical setting because of this commitment and this sense of, I think, moral obligation. And unfortunately, it's setting them up for moral injury because that environment wouldn't be conducive to healing. It's like sitting in an acid environment, right? And it's just or high a lot of bacteria around, or a very much I'm trying to think of the like a polluted field, right? And you're just sitting and
Uh-huh.
hoping that you're going to heal, and there's a lot of contaminants in there. And so if people are not healing, they're going back and they're like, why can't I get better? If they hear you, I'm hoping that they can say, oh, because it's not just burnout, there's something deeper. And how can we create lives in alignment with our values? Because that's something strongly necessary in order to create the environment to heal.
Yeah, and I think a couple other things I learned about moral injury is that one of the most powerful things is free, and that's having conversations about it.
Mm-hmm.
So I interviewed over 30 people, and a couple of them came back to me and said, just telling you that story, I felt better. And I was like, well, I'm a psychiatrist, so of
Yeah.
course I know
Uh-huh.
that, right? To
Mm-hmm.
me, that's intuitive.
Yeah.
Um, and then they inspired me to include some painful stories of my own in the book, which I was really nervous about. But I
Mm-hmm.
was like, well, if it was healing for them to talk about it, if I send it out into the world for anyone to see, maybe that will be healing for me as well as healing for them. And so, one of the best things for moral injury is just to start talking about it. Like you said, everybody thinks they're alone,
Mm-hmm.
and you are totally not alone. I published this painful story at the beginning in the first chapter, and I've had a couple people even in the last month come back to me and say, oh, I'm so glad you wrote that. I had something just the same happen to me and I never told anybody. I thought I was the only one. Like literally like 5 people have already come back to me and said that. So I think this stuff is happening, and that's not patient facing. That's just the injury that I dealt with of having a complaint against me with my own medical board, who you think is there to like support you and help you. And so that wasn't even a hospital or a patient or anything. That was like the people I thought were there to protect me. Um, so I think just talking about it is the first thing. And there's a lot of power in, like you said, holding space and being kind and gentle to one another. I
Mm-hmm.
also heard a lot of stories where clinicians inadvertently perhaps were really injuring one another.
Yeah. That was my
And
fear, actually. Mhm.
I looked back at some of the things I did and it's like, wow, I hope I never did that. But there were a couple times I was like, well, man, maybe I did actually inadvertently cause harm. So that was another big aha. And again, I think the focus in the popular press is now around, it's starting to shift a little from burnout and saying the system is broken and AI and all these other things. But I think they're still kind of missing the point. To
Yeah.
be honest, I don't, you could have the best tech in the world. You could have the best operations in the world. You could have the best, fanciest office in the world. You could have all the bells and whistles. Everything could be perfect. And you might still feel this way.
Mm-hmm. Mm-hmm.
And so I think there's a lot of time and energy focused on operational fixes because that's what people, they're industrialized. That's the whole point. Medicine has become industrialized. So they think about the fix
Yeah.
in an industrial operational way as opposed to my shrinky perspective, which is it's emotional
Yeah.
and people don't want to talk about emotions. They're uncomfortable. I used to be uncomfortable, but I trained and practiced so I know how to do it now. And it's not as hard as you think. Like you don't have to be a psychiatrist to have a hard conversation,
Mm-hmm. No,
right? You don't have to.
It's what's missing. I was so drawn. I wanted to do palliative care, hospice and palliative care psychiatry. I was drawn to the not only the deep emotions, but in the most vulnerable times, such as facing our own mortality. And I find you hear, I resonate a lot with the spiritual crisis. Our medical system is in a spiritual crisis where I subscribe to we're spiritual beings living a human experience. And I agree with you. And at risk for PTSD in healthcare, if you are stuffing your emotions down and not processing, like that is when you just kind of get this chronic trauma and put people at higher risk. So I love that you said talking about it. And I'd also add the talking about it in an environment where they're validating, it is safe. People aren't, if they're invalidating you and you're like re-traumatizing you and they're gaslighting you into thinking that like your story isn't real, or like, oh, well, you didn't go to war, or, I did that to myself. Well, I wasn't deployed. I didn't do this, right? And like minimize. And so just saying that for talk, especially to people like you that really have the skill and understanding to receive that emotion and to sit with that person as they experience and process through. Because the wounded people wound the other people, right? Hurt people hurt people.
And that's what I think, again, the narrative I'm hoping to evolve is that it's not us versus them. It's not clinicians versus administrators. That's not productive. And
Yeah.
these aren't villains for the most part. But yeah, they can be wounded themselves. They can be burned out or wounded or PTSD, and then they externalize. I laugh. There's a story about surgeons in my book. I found surgeons to be the most externalizing people I've ever met. It was like
Yeah.
remarkable.
Mm-hmm.
And they get angry and they act out, and it's so that's how a lot of surgeons I know dealt with their anger. But I did have a patient I included in the book in my own psychiatry practice who was, let's just say, one type of surgical subspecialty. And that individual internalized and on the surface was the kind of physician everybody wants to be, nice, top of their game, good looking, accolades, researcher. Like you would just look at this person, be like, wow, I want to be that person. And they were crying in my office, telling me they were thinking to kill themselves.
Yeah. Mm-hmm.
So, yeah, I think I guess I just don't like the false narrative about us versus them.
Yeah.
And we're all human. And I don't think it's counter, you can be a wonderful clinician, a wonderful physician, a wonderful nurse, and you can be deeply human and vulnerable and emotional. I don't think those two are mutually exclusive, but I think in our training and the culture we put ourselves in, especially, again, I'm just pointing to surgery because I remember my experiences so vividly on that one. Like
Yeah.
I found that I loved surgery. I would have totally considered being a surgeon, but that culture was really brutal. And um, yeah, I think it gets trained out of us. It's hard to be perfect, and we're not perfect. And having that expectation leads to a lot of emotional distress.
Mm-hmm.
Um,
Yeah.
so that's one thing I think. And then the other thing is, at the same time, even though we want to heal, we can't really just go backwards because medicine has changed, healthcare has changed. Like there's so many more complexities and treatments and ways of thinking, understanding of Eastern and all these other different healings. And for one human to know all those things now is impossible.
Yeah.
So we can't go back to the example I give of my grandfather who after World War II had a little bag. I have it right here. Everything he knew was in his little bag. He had a little bag. He made his own medicines. He had his own syringe. He went out and that was it. He had a recipe book, how to make medicines. And you could be a doctor and that was all you needed. Like we can't go back to that, but we kind of long for the nostalgia of that.
Yeah.
So we have to find a way to look forward, I guess is what I'm trying to get to as well.
And capturing that avatar of the surgeon and the internalizer, I'm very sensitive. And actually, my internalization came out as anorexia. It was like, well, I internalized and like,
Mm.
just like, and I was suicidal, which is why I left surgery. And I anticipate it's a lot of that. You have to look perfect, know it before you learned it. In surgery, you can't ask questions. You're supposed to already know. And that I come from a town that was really high pressure academically, and there's a lot of high suicide, high substance use. And this belief, what was important to both of our messaging is we have to humanize people. to give them the opportunity without judgment to say what they're going through, because I had so much shame and guilt that I
Mhm.
isolated. And that is what and I'm sharing because I know it's common. So forever is listening and thinking about, well, I'm that surgeon. What do I do? I'm like, well, they talk to you, right? Take down that pressure of needing to look and to appear perfect. And with that, it can create a lot of destabilization in the identity of a person who thought they had to be perfect in order to XYZ, which is often prove their value, prove their worth, feel like they have meaning and value in the world. So it's like, how can you extract your worth and value and create an identity that includes way more than just that part of you so that you have more stability so that you can really face these emotions and what you're processing without it completely causing you to implode. And for me, that was wanting to take my own life because peeling back these layers was like, who am I without all of this? And so what I'm saying now is how can we protect ourselves? And I find it's from creating more robust identity and challenging our perception on what it means to be a good clinician or a surgeon or whatever, high achieving, whatever.
I'm sorry that happened to you.
I'm glad it did though. You know what? Because it's like the in time, if I didn't experience that, I may not understand, right? But I understand it. So I sat on my deathbed and thought I wouldn't be here. And it's with that experience that I don't care to what people are going to say, if they're going to be like skeptics. I'm like, well, that's fine. But we hope that this message that we're both sharing here today is going to allow people to get the help they need so that we can save their lives. And I wouldn't have so much conviction and I wouldn't want to yell from the rooftops had I not experienced what I had.
Mhm. Yeah, that's powerful. And the fact that it took you to get there to make that change points to how hard these wounds are to heal.
Yeah.
Um, well, I can share, in terms of healing, what people I interviewed told me, and what sounds like you've experienced some ways to heal by looking at the bigger picture. So here are some things I've heard, and I would preface this first of all with saying that we are human, which means we're not all the same, which
Mm-hmm.
means what works for me isn't going to work for you. So I
Yeah.
can't say everybody should go do this or everyone should go do this. All I can say is there's some other ways of thinking, other frameworks, ways to get curious. And I can tell you what other people have shared. So people, including you, have shared with me one way they found healing is to turn around and heal other
Mm-hmm.
clinicians. That's something I like to do. I try to do a lot of that. That is healing. Sometimes that shows up as mentoring or advising other younger career
Mm-hmm.
um, trainees. I've seen that. Teaching, I think, sometimes feels good to people. Another way I've heard some people feel is healing is to become more of an advocate,
Mm-hmm.
and to sometimes that's individual patients. But then I've heard a couple people say, well, I felt when I was advocating for one patient, I was just like rinse and repeat, and I was just banging my head on the wall. But when I joined this committee, or I got involved in this action group, or I did this petition, then I started to feel like I was making more of a difference. And they said that knowing, yeah, of course, it's not going to change everything overnight, but I felt much better being part of the solution
Yeah.
in
Mm-hmm.
addition to being a clinician. So that was something I heard a lot. And then I heard a lot of folks who have been coached in some way or have had therapy say just knowing what to call what they were feeling, and just knowing they weren't alone, knowing that maybe they'll never talk about it to anybody else, but at least knowing they're not alone and knowing that others are vulnerable too,
Yeah.
that made a big difference. Another thing I heard was once they get past some of the emotional content, it's a lot easier to see options. So
Mm-hmm.
you were alluding to other options than traditional whatever surgery
Yeah.
OR, additional than me psychiatry outpatient. Like,
Mm-hmm.
I'm an advisor, I write books, I see
Yeah.
patients, I
Mm-hmm.
love to do more than one thing, but that's me.
Yep.
I've known physicians who run companies, who are political, who, there's a lot of different options to us. We have a really wonderful degree. I'm happy that all that pain and suffering to get that degree. We really do. And we forget that sometimes, that we have a special way of thinking. that translates outside of just a patient interaction. So I hear that a lot. And then for me personally, and I've talked to some others who said the same thing, maybe what you were saying too, alluding to being a whole person and creating a life where I'm a whole person instead of just a professional person.
Yeah.
And I hear people say it with their family, and then you get into this like work-life balance conversation, which I don't love either. I always feel like that doesn't resonate with me. I
Mm-hmm.
want to feel like a human being. I want to feel like Jennie. And
Mm-hmm.
Jennie likes to play music, and
Yeah.
Jennie likes to do this, and she likes to make things with her hands, and she likes to read books and blah, all the things that make me me, which are different for everybody. I went back and thought, well, what before medical school, what was I doing? I did other things. What
Yeah.
was I doing?
Mm-hmm.
And it turns out there was a lot of stuff that I re-engaged with now, and then there's new things that I've been trying. So rediscovering that sense of like, who am I? And like you said, what makes me me outside of this job? I'm not a job.
Mm-hmm.
So I don't know. I'm curious, other than this work, what you found, anything you've rediscovered in yourself.
Oh, a whole bunch. I love connections, relationships. One thing, I just started a master's in marriage and family therapy. I am doing trauma and as my study, my focus. I love to get to know about people, existential questions. I've dealt with life-threatening physical illness that went along with my eating disorder, and I like to sit with people as they face very serious illness and they ask themselves, well, what does this mean to me? And get in alignment with their core values, right? I just feel that there's Viktor Frankl's The Man's Search for Meaning book, and creating meaning helped me to sustain myself. For anorexia, I think it's like, I call it starving for meaning. It comes up for me when I'm lacking meaning, and I find meaning in what you just said. Everything that you captured it pretty much sums up what I've been investigating. And I just am going to start learning guitar. I love music. I played percussion. I'm tone deaf actually, so I like the beats. I like to be goofy, but I lost that. And I think a lot of people lose it when we are in survival mode. And so as I have um, just kind of been processing through, I did develop PTSD, and I did develop things that didn't allow me necessarily to tap into creativity because my body always felt like survival mode. And so when I'm creating safety now and giving myself, I always say, give myself permission to not go back into the trenches. I was going to go do psychiatry residency and chose a master's for my own continuation of this healing since I was vulnerable.
I would say, and I would challenge you to even go a step further than permission. I would say that for most clinicians I know, if you lean into what is meaningful and what makes you you, even if it means you spend less time at work or
Yeah.
less mental energy at work, you will be better. Your patients will heal better. So if anyone's listening who's a frontline clinician, I would
Yeah.
challenge you, if you take better care of yourself and lean into your identity, being whole or as close to whole as you can be. I believe, I'm a neuroscientist too. There's a lot of evidence that healing happens when human beings synchronize.
Yeah.
They literally synchronize brain waves. There's really cool new research with a therapist sitting in a room with a patient. That therapist does better and that patient heals more when their brain waves are synchronized. So there's
Yeah.
literally electromagnetic energy that is in your brain and around your body. And when you show up to take care of a patient and that energy is aligned because you have found meaning and you're more consistent with who you are, I don't know about how I could guarantee this exactly, but I would guarantee that your patients are going to feel healed in a different way. You could be the most competent clinician, show up, check every little box, do every screening, be perfect on all the meds, be timely, be professional, be kind. But if you are not connecting with them as a human being, I don't believe they're going to heal as well. I have just seen
Mhm.
it too many times in practice. How you show up is part of the healing. And if you show up, you can't fake it. You
Mhm.
can't put a smile on and fake it like that. The body's just, we know we're tuned. We're very finely attuned
Mhm.
to one another.
Mhm.
So I guess that's my challenge. I wouldn't even say
Yeah.
permission. I would say if you want to be good at your job as a healer, you better heal yourself because you're going to have trouble being a good healer. It's just
Yeah.
really hard.
That's what I thought was because I value relationships, I wanted to learn psychotherapy no matter what. And the master's in marriage and family therapy, I like to work with patients with cancer and their caregivers are really impacted. So I'm like, it actually the tools I'm gaining were in exact alignment. And like you said, it just looks a little different than what my brain originally offered me as an option because of the linear path I had I'm so far from a linear path at this point, it doesn't matter. But it was grounded on my values and maintained my values during the education. And when Beck has a book called The Way of Integrity. Have you read that book?
Yeah, I know that one.
It captures what you said. If you're
Yeah.
not in your integrity, you're betraying yourself, you're lying to yourself, your body will know and other people will know. And because again, the energies will just be off. So I recommend your book, of course. I recommend them getting that book. And and I also had heard it only takes about 20% of like doing things that are fun to help give that energy back to the 80%. So like if you're fried and burn out, like you don't have to toss your whole career out the window, but create enough space in your day to do like this 20% is for me and like what I enjoy outside of my job.
And probably not even that much, honestly. I mean, I noticed when I started playing music again, I decided to pick up a new instrument. I started out with about a 45-minute lesson a week, and then I was practicing, I don't know, maybe like 2 nights a week for half an hour. That was enough to get me started, because that's something that really had deep meaning for me, and I had just kind of forgotten about it in med school when I had to drop all my instruments. So yeah, I think we can challenge ourselves. I also hope that folks reading the book or listening today, you are not helpless and you are not hopeless.
Mhm.
You are needed, and whatever you choose to do has value, and you are not hopeless and you're not helpless. And so I do want to encourage clinicians to challenge themselves a little bit. And maybe, a lot of physicians in particular, I know, we're really good learners, obviously, to get through, right? We had to figure out how to learn. And if you can learn, like lean into your learner and your curiosity
Mhm.
mode, some folks find that easier than like more of the therapy mode, which is
Yeah.
very hard for them, or
Mhm.
emotions. But if you can lean into your cognitive curiosity, like, I wonder what Jennie was talking about, that moral injury. Maybe I should read that book, or maybe I should look at this, or maybe I should, try that. Maybe I should pick up that thing I haven't done in 20 years,
Mhm.
and just kind of lean into it cognitively with your like learning mind, as opposed to trying. I know most people aren't comfortable going deep with their emotions, especially without someone to help them.
Yeah.
So even just cognitively, I think if you lean into some curiosity and learning, like just read a couple articles on, like you said, PTSD versus burnout versus moral injury, or listen to a couple of podcasts, like just be really curious, and people say, oh, I don't have time. I kind of don't buy that. I
Yeah.
have to be honest with you.
Mhm.
Like, that's kind of BS in my mind. Like, if you put your phone down for 20 minutes and read an article on like this topic, I'm sure the world would be okay. If you
Mhm.
turned off the news for a week and got curious about something. So, the time crunch I wrote about in my first book, and I think time is being used as a proxy. But we do have choices on how we use our time, even if we are an active clinician. And you do have choice. You can put your phone down. Uh,
Mhm.
it is a
There's
choice.
there's so much scarcity mindset in time and in money, and especially in the physician space. And I just got done with the book. Was recommended to me by a dentist coach who's amazing, and it's called The Illusion of Money. I recommend that book.
I don't know that one.
It's written by a former actor. It's by Kyle Cease, Cease. But it challenges what we believe. People are afraid to leave their clinical job because of money. People are not able to carve time because of time scarcity. And these are certainly, I would challenge what their perception as well, just reiterating what you said. And you mentioned about they are not hopeless. And I did feel hopeless at times. So if you hear Jennie now, borrow her hope. She is telling you, you are not hopeless. Your mind might offer you that you are hopeless and helpless. Well, that's a state of very deep sadness, and you're maybe not have energy right now. I trust Jennie's judgment here. You are not hopeless. You are not helpless. You are very skilled. If you need to borrow it from this conversation, please do. and just having that sliver of difference. So you said curiosity, and curiosity without judgment, right? I'm curious, right? Or even with the brain, like my brain's offering me, I'm hopeless, worth of poop, hopeless and worthless, and piece of poop right now, right? I'm curious why I think that, where I got it from, right? And that can be painful. So maybe, having that curiosity with the support of someone like Jennie who can partner with you, but that,
Or be curious and say, Dr. Jenny's full of it and she doesn't know what she's talking about, and go look it up and challenge me
yeah,
and, reach out to me and say, hey, you're full of it. You don't know what you're talking about. My life is miserable. And then we'll have a conversation. And the hopeless, helpless is something I learned in psychiatry training that was very powerful for me, which is people who are thinking about ending their life by suicide. The common myth is that um, they'll never change their mind. But the reality is, you work with folks as a psychiatrist, and the vast majority of them actually don't want to end their life.
mhm,
They're just, like you said, their brain is in a cognitive emotional space where that's all that they can think about, but that's not their fault. It's your brain is telling you something,
yeah,
and it's because of what's happening to you and the wiring of your brain. And maybe you have some chemicals that could help, or therapy that could help. But I can tell you, the vast majority of people that thought they were always going to be suicidal and feel that way really aren't.
mhm.
And with some time and sometimes professional help or coaching or not professional help, um, it does change.
Yeah, I called it psychic. Like my brain just felt like it was in such deep emotional pain that I just wanted to end the pain of my brain, but not necessarily my life. I just couldn't think about anything other
Mm.
than the pain that was in my brain. And so for someone to keep you safe while you are processing and allowing your brain to recover from that so that it can see multiple different ways. Because I do know at my time when I was in surgery, I thought I either had to finish my residence. My lights are back on. This is amazing, friends.
Joy.
Joy, I thought that I needed to finish surgery or take my own life because at the stage that we do that training, we don't have often people don't have a whole lot of life perspective to balance their identity. They have so much familial pressure. And what I kept seeing in the crisis unit on my psychiatry rotations are males that lost their jobs. And so a lot of my messaging now is to spare people from believing that their worth is tied to their jobs, their careers, the money that they make, because I felt how at risk that puts us to take our own life when things become unstable. So you're hearing it from us. Challenge us
Yeah,
and
that's
tell
what
us.
I be
Yeah.
curious, challenge us, read something and send it to me and say, hey, you don't know what you're talking about. Like, I'm all for that curiosity. There's a couple other things I've been telling people to try. I love the idea of doing experiments, right? That helps me be non-judgmental. So I'm a
Yeah.
scientist. So what would happen if, you did this? And so as a happen, and I've tried this in my own practice, so I would challenge you guys. What would happen if you started the conversation with your patient instead of saying, why are you here today? Which is negative, frames them in a negative mindset, changes the whole conversation. What if, and you try to be nice, oh, how are the kids, blah, blah, blah. That's small talk. That doesn't always work. Try this experiment. Ask every patient that you see, hey, I'd like to do something a little different today. Before we jump in, could you tell me a little bit what's most meaningful to you in life?
Mm-hmm.
Or what are you really good at? What are your strengths? What do you love about yourself? And then observe how the rest of your interaction goes with them. That's a fun challenge
Yeah.
to try. And then another fun challenge for for us when we're more in a patient mode or maybe talking to our peers is to tell somebody in a genuine way without any other comment, thank you for all you do.
Yeah.
Thank you.
Mm-hmm.
Just do that. Do
I
that for a
already
couple days and see what happens.
I love it because oftentimes when I got under the impression of I'm broken because I'm depressed, I just thought that I was miserable and hopeless and focused on the negative aspect of my brain's not working. But I learned to ask, what's depression telling me? And it was the completely appropriate response to the circumstances of not sleeping, not eating, being in a high stress. So it felt like even my eating disorder, I reframed it. It's like the canary in the coal mine. And then for you to focus on things that are, even if you think you can't necessarily feel joy or optimism, well, what does or what did matter to you before you got into this dark place? Because maybe you have to reach back there. And it's even framed when you get a survey about patients, a patient survey.
Mm.
If they frame the questions in a positive way versus a negative way, their answers will be different.
Lots of science on that. A good friend of mine, Dr. Alan Schlechter, this is what he does. He's at NYU psychiatry. He wrote a book on this. He teaches NYU undergrads the science of happiness,
Mm,
and he researches this. And he just started a program for residents to teach them to do something called a positive approach interview, which puts the positive at the front of the interview instead of at the end. And it demonstrates much better clinical outcomes than patients getting a traditional interview. So that's why I said try it.
yeah.
If nothing else, try it with a patient because you're probably comfortable doing that.
Hmm.
Try it with them. I've been really surprised. I challenged myself to start doing that as part of my practice. And sometimes people can't answer. And that also tells you a lot. If you have a
Yeah.
patient in front of you who can't say anything they're good at, they can't say anything that's meaningful to them, before you start talking about their diabetes, like you should take a hot minute and like think about that because everything you say isn't going to matter,
Mm,
right? It
yeah.
doesn't, you could talk about all their medical issues or it won't matter. So
Yeah.
getting curious, like again, it's an experiment. Try it for a week or two. Send me a message, say, hey, that didn't work. Um, you know, I just,
Mm,
I think we can challenge ourselves. I think we're very resilient people at our core. I also challenge the idea that clinicians are not resilient. I think we
mm,
would not be clinicians if we weren't resilient. So if we're not
yeah.
looking resilient, that should tell you something.
Yeah, it's absolutely absurd. I think resilience has become such an activating word for so many, and even mindfulness and things because
Yeah.
we know that there are systemic contributions, huge systemic contributions to everyone's stresses. And I think that when they feel victimized and blamed, it's just everything becomes a buzzword for being really upset and angry inside. And we are certainly saying the system is causing a lot and contributing a lot to this moral injury, the burnout, the PTSD, and what you have within your own agency. Because if you can empower yourself, know you're not trapped. And these are things I'm just reflecting back to some comments that you've made here is like just thinking what you do have agency over. And it's that, okay, well, if you don't have time, meet with Jennie. I don't know the capacity you're going to have if all these people are meeting with you, but reach out to me,
Reach
reach out
out.
to
If I
Jennie.
can help you, I
Yeah.
guarantee I will not ignore you and ghost you. I will try to find somebody who can help you.
Yeah.
Just the act of reaching out is a big step. So if you're feeling emboldened after listening to this, don't waste that opportunity. Just reach out. I promise I'll answer. And um, yeah, and kindness is just underrated. I just think kindness is so underrated. You could be
Mhm.
very burned out with PTSD and moral injury, and if somebody comes up to you and says thank you for all you do, it touches you. It touches
Mhm.
me. Like it matters. It may not fix everything or heal everything, but like small acts of kindness don't take any time, really. And I think it's really underrated. I think kindness goes a long way, honestly. Maybe I'm sounding like a Pollyanna, but I do believe it.
I do too. And also, people are really self-critical in medicine and high achieving. Okay, the challenge for the people listening, I'd even say down below, right? If you were to answer her questions, if you were the patient, share
Yeah.
down below what you value, what you're good at, see how it feels. Do reach out to somebody close to you. Tell them how much you appreciate them. I'm somebody who lost my ex-boyfriend suddenly. So I really appreciate when someone says, don't assume they know that you love them. Don't assume that you're gonna be here tomorrow or they're gonna be here tomorrow to tell them. Tell them now. Assume they don't know how much you appreciate them. Like I want to tell people how much I appreciate them so much that they're nauseous. Like that she constantly tells me how much she loves me and cares and like how much I matter. Like, yeah, I know what it felt like to not feel like you mattered. So I'm gonna remind you just in case.
Yeah, and I think this is where some of the modern ways of working are wonderful because we have text and emojis. So you don't have to take, literally just pull out your phone and scroll down and say, oh my God, this person was such a meaningful person in my life. I haven't talked to them in forever. And literally send them a text and say, hey, I was just thinking about you and how much you helped me. Thank you, with a little emoji.
Yeah.
Literally, I just challenge you to do it, because it'll blow your mind, like what happens when you do things like that. And it really doesn't take any time.
Well, I want to just say right here, you joined me when I was in a hurricane. I've sent you like emails frantically. You accepted my invitation to come on this channel and share a very important message. I appreciate that you're giving me this time and opportunity. So thank you, Jennie.
Thank you. See, even that, like, seriously, that really touches me and it matters. So
Yeah.
yeah, I hope this has been helpful for anyone listening, and at least make you think about things in a slightly different way. But you're not alone, and you're not helpless, and you're not hopeless. I promise. So thanks, Jillian, for all you do. Thank you for putting the word out and for helping others. And love the fact that you're going back to do therapy. I can tell you, I was a miserable, terrible marriage and family therapist. So I hope you're better at it than I was, because I was actually quite terrible at that.
Okay, well, I will do that part if you can help
I'll
with
do
the
the other part.
Okay, sounds good. And
Deal.
for the people who we asked them to connect with you, what's the best way for them to connect with you?
Honestly, LinkedIn is probably the easiest way. Everyone's on LinkedIn, even if you're not active on it. You can send me a connect request with the message, or if you're already connected to me, I'm pretty promiscuous. My connection acceptances. Yeah, just reach out to me, and if it merits a phone chat, I'll send you a link to my calendar. And I always try to make time in my week for impromptu conversation. So yeah, I think LinkedIn is the easiest way, honestly.
And you said, it's really important if people feel comfortable at the level of detail you want to just get it out there. Again, share with Jennie, share with me, share in the comments what you feel is important just to share, get it out, see how it feels. This is a safe space. If people start to troll, I just delete them so that you feel safe to do what you need to do. And the book link will be down in the description below, and it's behind you. Thank you so much for writing it, Jennie. Thank you so much for being here.
Thank you, Jillian.
All right. Until next time, friends.
Okay.
Thanks for watching.